Thank you. Thank you so much for that introduction. And welcome everyone to this talk on the role of psychology in solid organ transplant care. Just to introduce myself, I've been working at Loyola for the past 10 years, and most of my work has been with the solid organ transplant service, particularly heart and lung transplant, cardiothoracic transplant. So my talk is to give you a general introduction on the role that I play on these teams and the ways in which psychiatry and psychology can contribute to assessment, evaluation, and care of patients through the process of solid organ transplant. All right, so just to give you an overview of the talk, I'll talk briefly about history of solid organ transplant, some of the present a rationale for why we are involved in the process of psychosocial screening, what the evaluation process looks like, specific areas that we assess, and then to give you some case examples of some patients that I've encountered over the years that have posed psychosocial challenges. So an overview of the history of solid organ transplant and more to, I've listed these dates just more to give you a general sense of how nascent this field is, how most of the developments in transplant surgery have been over the past 60 to 70 years. Some of the important dates that stand out here is 77, which was when UNOS, which is the United Network of Organ Sharing, was created, was introduced, and it was the first computer-based organ matching system. UNOS is still the organization that coordinates allocation of organs, it manages wait lists, and it also manages the donor and recipient profiles. And it is the primary link between the organ procurement organization and the transplant center. So if an organ does become available, UNOS is what coordinates making the call to the transplant center, trying to see whether they would be willing to accept this specific organ and arranges for the procurement. So that's an important date. And then because I work in the field of lung transplant, particularly 1983 is a very important year with the first successful lung transplant. It is also an important year because a very powerful immunosuppressant called cyclosporin was introduced, significantly improving outcomes and longevity with transplant. So these are some statistics I just pulled this morning off of the UNOS website. And it's pretty sobering in terms of giving you an idea about how many people are waiting for organ transplant at any given time. So as of today, there are about 108,687 people that are listed for a life-saving organ transplant. 67,000 of those are active on the wait list. So some patients may be deemed inactive for multiple reasons, if they've developed some medical complications or they are out of the country for any specific, urgent need. People can be deactivated or deactivated for short periods of time and then be reactivated. But so about 67,000 people actively waiting sick and in high need for an organ transplant. These are some numbers for this year. 32,539 transplants have been performed, and this metric has steadily been increasing year upon year. With I think between 2018 and 2019, they showed about an 8.5% increase in the number of transplants that have been performed. And we have about 15,000 donors that have been listed for donation between January and October. So as I mentioned, these numbers are pretty sobering in that we know that the number of individuals who are waiting for transplant has increased almost sevenfold over the past 20 years, and this is because of pretty significant advances in medical surgical interventions. People are living longer and haven't succumbed to their cardiac disease or their lung disease, and so are at the point of then needing life-saving organ transplant. From UNOS, every 9 minutes, someone is added to the national transplant wait list, and on average, 20 people die per day while waiting for a transplant. And that is the most sobering number here because it really presses on all of us that are involved in organ transplant how important it is to make good decisions about candidate appropriateness and patients that are being listed for transplant because so many people are dying on a daily basis. At Loyola, this is what the organ transplant team looks like. I enjoy working. I'm a health psychologist, and I enjoy working in solid organ transplant because I truly believe it has the true essence of what a multidisciplinary team looks like. I work with any of these people on a daily basis. The transplant surgeons, physicians, transplant physicians, the coordinators, nurses, procurement coordinators that have the special task of actually going and procuring organs, the social worker that is a very critical part of the transplant team, the psychologist or psychiatrist, the nutritionist, pharmacist, and pastoral services. So some of the stages of the transplant process. The process of transplantation begins with referral being made by the doctor to the transplant team. So most of our patients are following with local pulmonologists or local cardiologists, and then are referred to Loyola because it is a center for transplant care. And so that initial transplant proposal is made by their local doctors. Once they have been proposed as potential candidates for transplant, they go through a pretty intense evaluation and assessment process. And the evaluation process can take a couple of months sometimes because they have them completing several medical tests, scans. They also do a nutritional consult, a psychosocial consult, a financial consult, in addition to, of course, any number of visits with the physicians, with the surgeon, to be able to have a good understanding of what the transplant surgery is going to look like. So this is a pretty in-depth process, and much of the feedback we receive from patients is that it is pretty exhausting. And at this point, it is when patients truly make the commitment towards a particular institution to be able to proceed with transplant there. The next part, after the evaluation has been completed, a waiting period follows during which all of this information that has been collected from the patient is presented at a medical review board meeting. We attend these meetings weekly, where all new patients that are being considered for transplant are presented, and a very multidisciplinary sort of discussion ensures, where everyone puts in some information that they have been able to gather about this patient, and a team decision is made about whether this person is an appropriate candidate for listing and proceeding with transplant. Once the patient has been accepted as a candidate for transplant at the center, they are listed and a score is calculated for them. That score is based on a very complex algorithm that UNOS puts out, which factors in a lot of medical, psychosocial criteria, nutritional criteria, to present a score on which patients in a particular region are ranked. Once the patient receives a score, it is a waiting period up until the right organ based on size and type, blood type, is found, and also their need in terms of where they feature on this list. Once the right organ has been procured, transplant coordinators, procurement coordinators go out, receive the organ. A decision is made about whether the site wants to accept an organ. And then if it is flown, the organ is flown back to Loyola, and then the surgery is performed. Surgery can last anywhere between 8 to 10 hours. It's a long, arduous process. And then the patient recovers in the hospital, on average about 2 weeks if everything goes well, much longer if there are complications. And then it's the post-surgery recovery period. So what is the role of psychology services through all of these this long, intense sort of time that I've spoken with you about? So we are involved in the psychosocial evaluations, which is the first time that we meet with patients. And we play a critical role in screening patients and living donors prior to transplantation on a number of psychosocial criteria that I will discuss. If during the time of evaluation, a patient is identified as having some sort of a mood disorder or any other psychiatric disorder, we may be actively involved in diagnosis and treatment of this disorder through the early transplant stages. We provide a lot of support and counseling before and after transplantation for patients and their families. We also serve as a point of education about stress management, enhancing quality of life during and after transplant. So the transplant evaluation process. So about more than 95% of U.S. programs at this point utilize some form of pre-transplant psychosocial evaluation, and about 25% of U.S. programs actually require a formal psychological test as part of the screening process. This psychosocial evaluation can be conducted by either the social worker, a psychologist, or a psychiatrist. At Loyola, we have most patients meet with the social worker and the psychologist. So what is the rationale for the psychosocial screen? We want to develop rapport with the patient and the family, and it's a good time to be able to get sort of a baseline measure of the psychological functioning of any of the patients that we see. We also want to learn whether the patient will be able to form collaborative relationships with the team, because this is a lifelong commitment and a lifelong relationship that these people are making. Post-transplant, the patients have a very rigorous follow-up schedule in transplant clinic, and they pretty much are sort of tied with the team, joined with the team for the rest of their lives. So we want to make sure that they are able to have trust in the team, be able to collaborate if there's complex medical decisions that need to be made. I said about establishing baseline functioning. We also want to be able to have some sort of a prediction that we can make about the patient's ability to cope with the stresses of surgery. And if we note any psychosocial needs that the patient might have or the family might have, we can work to actively find resources for the patient through this time. So what are the domains of evaluation? These are the 5 domains that I would say that most of our psychosocial evaluations cover in great detail. We first want to assess patients' readiness for transplant. We want to get a good sort of understanding of the compliance history of the patient, psychological stability, social support, and any substance use. There's a wonderful measure that was developed at Stanford called the SIPAT, which we use extensively at Loyola. It stands for the Stanford Integrated Psychosocial Assessment for Transplantation. It covers those broad domains that I mentioned on the previous slide. But what we like about the SIPAT is that it gives you a sort of strong a severity score, which is a good sort of objective measure of where this patient's candidacy lies. So the SIPAT, it's a new measure to address and conceptualize psychosocial risk factors for organ transplant. It's a good standardization criteria, and we found it to have very good inter-rater reliability between social work and psychology because we both administer the SIPAT. And it has been shown to have strong predictive power in research studies that have utilized the SIPAT. So the first domain that I discussed there, which is patient readiness, some of the big broad areas that we assess are, first of all, the understanding of illness. Does the patient understand, do they understand the name for their illness? Do they understand that it is a progressive disease? Do they understand how sort of medically sophisticated they are, and whether they have good health knowledge? So this is a good time for us to be able to assess that. We also, besides knowledge of their illness, we also want to assess their understanding of the transplant process. And some of the things that I might assess are, do they understand waiting list times? Do they understand how that is calculated? Do they understand how long of a time of recovery they will have in the hospital? Caregiver need, recovery time, what clinic follow-up will look like, and that do they understand that they are making a commitment to lifelong immunosuppression. So most of these patients will be on all of these patients, I should say, are going to be on immunosuppression for the rest of their lives. We let patients know that they will be sent home with anywhere between 30 to 50 medications. And we want to assess, are they willing to be compliant with that? Do they feel like they have sort of, the support to be able to make this a successful recovery? In addition, we also want to understand if patients are truly understanding of the risks and benefits of surgery. We inquire into whether they know what survival rates with transplant are looking like, what the national averages are, what Loyola's averages are. We encourage them to have these discussions with their physicians. We talk in detail about rejection, immunosuppression, and then what life after transplant will look like, that they might potentially develop diabetes as a result of being on these immunosuppressions. And we have a discussion with them about quality versus quantity of life. The hope is that through this discussion of patient readiness, we can have sort of lay some seeds or lay some groundwork for setting realistic expectations for transplantation and recovery. And that if patients are feeling like that are unrealistic in terms of feeling like this might be just any other surgery and they recover and go home, that we try to have some more realistic discussions around. The next domain that we assess is compliance. What are the things we're assessing here? How compliant are they with their appointments, following through on doctor's orders? A lot of times we want to know about how they're taking their medications. Do they know how many they're taking? How do they manage their medications? Do they use a pill box? Do they have timers that they set? I want to try and understand how often in a week they may forget a dose of a medication. And this is all within the context of trying to explain to them that immunosuppression medications are a lifelong commitment, and there's very little scope for error with those. You don't want to be taking them late. You don't want to be skipping 2 doses because you could go into acute rejection of the organ. And so we want to make sure that patients really understand that this is a lifelong commitment to adherence on their part. We also, with many of our patients, want to assess diet and lifestyle changes. Many of our heart transplant patients have a significant cardiac history, and a lot of them have been recommended diet and lifestyle changes. Low sodium, not eating fried foods, having lower intake of fluids. And we want to assess, have they been able to be successful with management of some of these, recommendations. So compliance is one of the most studied aspects of transplant failure. We know that the numbers vary, but the impact is pretty significant. There was a meta-analysis that was done on transplant non-compliance in 2004, which showed that there was a 7-fold increase in graft rejection as a result of non-compliance. And this really indicates to us how important it is to try to gauge an attitude towards being compliant. We also know that it may be responsible for up to 25% of deaths after the initial recovery period. This is a table of a meta-analysis that was done, and you can see some of the areas, the sort of big areas for non-compliance include non-compliance with taking your immunosuppression, return to tobacco, alcohol, and illicit drug use. So it makes it all the more important for us to be truly able to get a gauge of how committed patients are to being compliant post-transplant. What are some of the potential predictors of non-compliance? Marital status. We know that singles are more likely to be non-compliant. We also know that social support is a strong predictor of improved compliance, potentially because there are people around you to set reminders, to be after you to take your medication. We know that mood disorders can influence compliance rates. And the most powerful predictor of non-compliance is a history of substance use. So 6 to 8% of previous alcohol abusers exhibited similar behaviors post-transplant. So pre-transplant alcohol use is predictive of return to alcohol use post-transplant. So during the evaluation, some of the ways by which I assess adherence is I have the patients bring their medications in. I look at refill status. I might ask some questions about them and how much they know their medications. Some of the questions I ask is, how do you manage your meds? How often in a week would you say you forget to take a dose of your meds? What is your medication routine? I might also help them download some pill reminder apps if they're having difficulty with, taking their medications consistently, attempting to try to help them improve some of their routines and commitments. Social support, which is one of the other huge areas of assessment and of concern for us. So, sorry, I'm not sure why that's not showing up altogether. So we know that social support is predictive of positive psychological and medical outcomes. It is one of the most consistent findings along with medication non-compliance. And that is why we focus so heavily on social support and non-compliance. So some of the types of social support that we assess is not just emotional support, which is empathy, caring, but we're also, especially for transplant, very concerned about having patients with concrete, direct form of support. So that is money, time, in-kind assistance. So just to give you guys an idea, after transplant, patients need to pretty much, for the first month, be at Loyola a lot, especially in that first month. They have their weekly check-ins with their doctors, which is a given. But if they have any other complications, they may have up to 3 to 4 other appointments in the week. So that is, several trips back and forth to Loyola if patients live far away. And sometimes some of our patients are in pretty remote geographic areas, 3 to 4 hours away from Loyola. So you can imagine, and you're not allowed to drive after transplant. So they need a lot of assistance and support with someone driving them to their appointments, sitting with them. We also request our patients to have 24-hour caregivers, especially for those first 1 to 2 months, which are pretty critical because if you spike a fever, if you're feeling nauseous, all of these could be potential symptoms of rejection, and someone needs to be sort of very alert to these, monitoring this so that it can be brought to the attention of the team and the patient rush to Loyola immediately if they're concerned that the patient might be potentially rejecting the organ. So it's a lot of burden on the caregiving system. And for this reason, we have patients identify 2 caregivers, not just 1, but 2. We want a primary and a backup caregiver. We know that that is not ideal. Sometimes patients don't have a lot of support, but we try as best as possible for them to come up with a good plan pre-transplant so that they're not sort of left out in the cold post-transplant with no way to get to Loyola or no way to be able to make it to their appointment. So this is another slide just about the benefits of social support. And as health psychologists, I'm sure you've seen this frequently. There's a lot of positive effects on buffering stress and also positive influences on the immune system. Compliance may also mediate the relationship between social support and health. Like I mentioned, the presence of having family members may improve your ability in taking your medications with reminders and things like that. Sorry. So these are, like I mentioned, our requirements. 2 available caregivers, primary and backup, 24 hours per day, needs transportation to clinic and also help with medication. Which brings us to the next domain that we are very closely involved with, which is psychological functioning. So there's a growing evidence of an association between major depression and elevated morbidity and mortality. Many more studies that are showing this, particularly with heart disease. We know that these are sort of the average, and this has been replicated in many new studies as well. Patients awaiting transplant, prevalence rates for major depression can be anywhere between 23 to 25%. And 60% of patients waiting for heart and lung transplant meet criteria for at least one axis 1 diagnosis. depression, anxiety, adjustment disorders. We know that these depressive symptoms can persist in the first year following successful heart transplantation and on long-term follow-up. So some of the common issues that we hear from patients when we are assessing mood symptoms, many patients will talk about fear of dying and not living to receive a transplant in time. Many of them talk about the sense of a loss of control that they experience, feeling like the doctor is making all of the decisions. Also the sense of, I don't know when transplant, even if I'm listed, I'm not sure when transplant will become available to me. There's a lot of worry and uncertainty about the future, a lot of dependency on others, and concerns about a reduced quality of life. Some of the areas that we assess in our evaluation, we for sure will talk about current emotional functioning, any past psychiatric issues or psychiatric medications. We talk about, what additional stressors, support, coping skills the patient has, psychiatric history, and also a family psychiatric history. So this is pretty, familiar, I'm sure, to all of you in terms of when we're doing a psychological assessment. We know that depression and anxiety are very common pre and post transplant with patients. We know that, I'm sorry, I think this slide may have repeated. I'm so sorry about that. With bipolar disorders, we're particularly concerned if there's a history of bipolar disorders, and this might likely be, and this mainly is because patients are on very high doses of steroids post-transplantation, and we know that steroids can, worsen mania, especially if there's a history of bipolar disorders. We know mood stabilizers can reduce that risk. So what bipolar disorder is not a contraindication to transplant, but we just want to make sure that patients are being well managed by a psychiatrist outside. A lot of times I may make contact with that psychiatrist so that we can have some sort of a good collaboration in patient care. Post-transplant, we may touch base just to make sure the psychiatrist is aware they had transplant and that he should be particularly mindful of any elevation in manic symptoms, etc. Research on psychosis is sparse. It's only a few case studies, but we know it is a very strong contraindication to transplant. And by that, I mean uncontrolled psychosis. So, even with a psychotic disorder, that is not an absolute rule out. We want to make sure that the patient is receptive to treatment, is, well connected with the psychiatric community, is receiving good psychiatric care. And if symptoms of psychosis are well controlled, this patient can be a fantastic candidate if all other areas are doing okay as well. Some of the most important factors that we are interested in sort of assessing, like I mentioned, we want to know the extent of the psychiatric history, how well the symptoms are being controlled, how compliant are they with treatment, do they follow up with their psychiatrist regularly, do they take their medications, and do they have good support? And I can talk a little bit more about this with some of my case examples. Lastly, with the area of substance use, and this is very similar to a SCID interview when we're looking at substance use. We're looking at what kinds of substances the patient used, quantity, frequency, length of use. We administer the cage sometimes, the items did you consider use problematic? Were you angry when others tell you to cut back? Do you feel guilty about drinking? Do you need something to steady the nerves in the morning? The most important, I think, is to assess whether the individual has insight into their substance use and if they are making a commitment. So most programs have different policies for the ways in which they manage substance use. Loyola's policy is, on average, about 6 months of being substance-free before you're considered for transplantation. And a strong commitment to remaining abstinent for the rest of your life. Some of the other areas that we assess: does the individual have any history of DUIs? What sort of psychosocial impact was there from the drinking or the substance use? any past treatment, substance abuse treatment that the individual may have received. We make an assessment of their risk for recidivism, and if there's a family history of any substance use. And this is, like I mentioned, the most important thing that we focus on. Does the individual have insight? Do they understand that their substance use was problematic? Did the patient continue to use substances after diagnosis of disease? So this, if someone tells me that they've been an extensive user of alcohol, abuser of alcohol, quit 10 years ago, completed a rehab program, and have been sort of off and on in AA, that's a very different picture of insight and commitment as compared to someone that was smoking up until their most recent hospitalization and has been abstinent only 2 weeks. Was smoking despite a diagnosis of COPD. Some patients have told me they've been smoking while they were on oxygen. All of this sort of, indicates to me that this individual has had a very hard time quitting, has been making some pretty irrational decisions like smoking around an oxygen tank. And that's a different picture from someone that is committed and insightful about their substance abuse history. And the risk profile for relapse is very different. If they were to receive an organ, be able to breathe again, how likely would they be to return to using some of these substances? So these are some, risk factors for recidivism. We know that that's a pretty shocking statistic right there, that, post-liver transplant, up to 50% of patients may return to drinking. And this is despite us, doing an extensive psychosocial evaluation, expressing to them that this is a lifelong commitment that they're making to never drinking again, never smoking again, that this is a gift that they received from the organ, and that we do tell them that for every person that receives an organ, 7 to 8 people die waiting on the wait list. So, this is a lifelong commitment, and yet we see very high rates of return to previous drug and alcohol use. So, some of the identified risk factors for recidivism are less than 6 months sobriety, a history of alcohol dependence and polysubstance abuse, and if there was a family or a first-degree relative with a substance abuse history. Some of the other risk factors we know are poor social support. If they're non-compliant with medical care in general, then the likelihood of them being non-compliant with some of these requirements is highly likely. Younger age, and also serious mental illness. Some protective factors are if patients live in a stable environment and have good social support, they may be less likely to relapse. If they're also provided with resources for abstinence, they may be less likely. And also if there's a recognition and acceptance of abuse as a problem, which is that insight piece, and if they've been compliant with substance abuse treatment recommendations post-transplant. So some of our requirements: we don't allow substance use of any kind, including cigarettes. If there is a history of abuse or dependence, we want at least 6 months substance-free, and we may check this through random urine and blood screens. We may also recommend an IOP or even AA for patients that might have difficulty with quitting or are actively using substances at the time of evaluation. We also recommend that if patients are considered high risk for recidivism, that they have follow-up with psychology post-transplant, just to be able to assess, the likelihood of them to return to using substances. So I thought it would just be helpful so Zoe, do we have any questions, or before I move on to the case example, or would you like me to address those in the end? What would you like?
So far, we have one question about the social support.
Okay.
So what support from the hospital or government is available for patients who do not have strong social support resources? Is it possible to qualify for a listing if one doesn't already have the required social support?
That's a good question. It's very difficult. So, you know, I sort of went into a little bit of detail about sort of the extent of support that is required because it's a lot of back and forth to the hospitals. It's a lot of 24-hour care that's needed, and unfortunately, we don't have no government program will provide a 24-hour support. At the most that we've been able to arrange is someone to come in for 4 hours or 5 hours, which does not meet the needs of transplantation. So unfortunately, if patients really have no access to support, they will not be considered as being good candidates for transplant or to be able to have a successful outcome with transplant.
Thank you. And then a question that I have is, considering all of the resources that a patient will need in order to receive a transplant, I'm sure that there are lots of socioeconomic divides in the patients who are able to receive a transplant and have the whole social support and all the resources to go through it. And as you've worked with patients over time, have you seen any kind of factors for low socioeconomic patients where they are able to pursue the transplant and receive the transplant that have helped them overcome some of those barriers?
Yeah, I mean, I think, so I've given several talks on the ethics of transplant, and I think it poses significant ethical dilemmas in terms of, the availability of some of these resources that we say are criteria for moving forward in the transplant process. Our social workers are so committed to trying to help patients sort of utilize every potential option that's available to them. I see them as being sort of the backbone of the program more so than anyone that works in transplant. They are really the glue that holds the program together in terms of being able to string some of these resources. So we have special financial coordinators that work with patients trying to identify ways that they can pay for their medications, multiple things that they can do, like help them with fundraising, help them with, applying for some programs that might be able to, cover medications for them. Getting them rides to the hospital, arranging for some things like that, places to stay. If they live 3 hours away, one of our criteria is that they have to, for that first 6 weeks after transplant, live within an hour of Loyola. So then we try to find them hotels or places on a sliding scale or free of charge that they can live in a safe environment as they're recovering. So, I mean, I do think that social workers really go above and beyond in their role in terms of facilitating some of them.
Thank you. That's great to hear. They really do seem like the backbone.
They are. Yeah. I don't think any of this would potentially be possible. These are sort of, guidelines that we try to adhere to, but we know it's not perfect. And, on the ground, the reality is very different in terms of candidates that present themselves. The team works really hard. And I think the talks that I've given on ethics really, sometimes it can be really shocking for patients, for people that don't work in organ transplant to hear about the sort of playing God, right? A team of people sits together and makes a decision about whether a patient gets a life-saving procedure or not. But, I've working in this area for so long, I've seen how much of a heart these doctors put into it, and none of these decisions are taken lightly. There's a lot. If there's ever a decision made to turn down a patient, it really is, with a lot of heart and consideration given to that decision, and it weighs heavily on the team. I know that. The sort of guiding principle here, will this person be able to have an effective recovery? And we've seen that patients that don't have a lot of these resources and support do not have effective recoveries. And so, we're able to argue in that way. But I think there is a lot. I think it's a fascinating field for just ethics.
I agree. Thank you so much for that response. It looks like we have 2 more questions. If a patient is medically unstable and may not be able to demonstrate 6 months of abstinence, what remediation can be considered? Can they still qualify for listing?
Yeah, and that's an excellent question. And we run into a lot of this, not as much in heart and lung transplant, unless the patient has come in with like a crisis, in a cardiac crisis. But we do see, my colleague that works in liver transplant sees a lot of this, where there's a sort of a liver crisis. The individual has come in to the ER in sort of, liver failure, and needs to be considered immediately. And a lot of times, liver failure is caused by a history of substance abuse. And so it becomes very difficult. It's impossible for them to be able to, I think they make educated decisions about whether this person is likely to be able to demonstrate adherence in the future with being off substances. Sometimes we don't have the benefit of time. I know that the team sort of tries every which way to be able to have the patient have time to demonstrate compliance, but if they aren't able to, then they make the best decision in the moment. A lot of times, these criteria hold true, but sometimes, age is a big factor. A younger individual that has a higher likelihood of recovery, has more years to live, may, have a different sort of weigh differently on the decision as compared with, someone else.
Lots of ethical considerations. It looks like our last one is actually a reference provided by Brittany Polenka, and that's for anybody who's interested in looking at more about transplant providers on social support.
Okay.
So you can continue. If other people have questions as it comes up, we can also address them at the end.
Okay, great. So just some case examples. This is the first one. So this is a 56-year-old male that was evaluated for transplant. He has a history of congestive heart failure, which was diagnosed 2 years ago. And through the assessment, this is what we sort of found, that his knowledge and understanding of his health issues and also of transplant was fairly good. His cognitive functioning was good. He had good motivation, strong desire to pursue transplant, good compliance history that he reported. He took his medications on time, was following up well with the doctors. He had a good support plan in place with 2 identified caregivers. So he looked like a good candidate. This was some of the stuff he reported to us. I apologize. I'm not sure why this thing is not showing up altogether. So the area that we had concern about was his current emotional functioning and his history of psychiatric issues. Patient reported that he had a history of depression, which started in his mid-30s. He was prescribed Zoloft by his PCP and had been taking it for the past 5 years, and had noticed that recently he had an increase in symptoms of sadness, anhedonia, sleep difficulties, and feelings of helplessness. When we inquired into coping resources, the patient said that his family was a big source of support. He used a lot of prayer, and he did a lot of, engaged in a lot of pleasurable activities, which improved mood. Family history of psychiatric issues, he says, was significant in his mother for depression. When we inquired into substance use, patient told us that he drinks about 5 to 6 beers per day, has been doing so since his mid-20s, and he quit drinking 3 years ago. So, around the time when his heart failure was diagnosed. He's never been in substance abuse treatment before. He says that he began smoking in his mid-20s as well, and he smoked about 1 pack per day, and had been able to reduce that and was currently smoking about 3 cigarettes per day. He has a family history of alcohol use, which was significant in his father and paternal uncle. So, most areas have checked out okay for this person, except, he's got some current and past psychiatric issues and this history of drinking and smoking. The drinking, he's been abstinent about 3 years, so he's really met the criteria that we have for, greater than 6 months. Smoking, he's still smoking. So some of our recommendations for a patient like this would be, we recommend substance abuse treatment. The fact that this patient is still smoking about 3 substances, smoking 3 cigarettes per day, it might be helpful for him to maybe use some aids to smoking cessation. If this individual also thinks that AA meetings might be helpful for his, history of alcohol use and the smoking, then that might be something that would be beneficial to keep him abstinent. We also suggested that, he's on this dose of Zoloft. He's reporting that with these new stressors with transplant workup, he's having increase in depressive symptoms. So we suggested that maybe he have a talk with his PCP about increasing his Zoloft. And if he felt like his PCP was not doing a great job with management and he wanted a little bit more of a specialized approach to med management, psychiatric med management, that he should maybe make an appointment with a psychiatrist. Okay? And we said you can contact psychology with any increase, if there was any increase or no improvement in his depressive symptoms after the increase in Zoloft. He seemed to have good coping skills. He wasn't very sort of receptive to psychology. So we said, okay, let's go the route of changing some of these meds and let's see if that improves things. Otherwise, we can maybe, come up with another plan. So that's a fairly straightforward, that's the sort of typical straightforward patient we see for the most part, but we also run into several other complications. So this is similar to what someone brought up. This is a 21-year-old male who is transferred from outside a hospital for evaluation and management of an acute liver injury. 3 days earlier, he had an altercation with his girlfriend related to her involvement with another man. He started drinking heavily, he says just beer, and became intoxicated and smoked marijuana. He then ingested an entire bottle of Tylenol PM, unsure how large, and part of a bottle of generic acetaminophen. He says he blacked out, he vomited several times, and then awoke the next day. He did not show up for work, and when his mother came home the next evening, she noticed that he appeared confused and just not himself. She found the empty Tylenol bottle and a suicide note and brought him immediately to the local ER. Okay. And at the ER, he was found to be in liver failure. So my colleague might be called in to do an evaluation, an urgent evaluation in the ER for a case like this. So on assessment, this individual was found, his cognitive functioning was found to be, he was awake and oriented ×3, but he showed response latency and demonstrated confusion at times. His knowledge and understanding of, sort of what had happened and his sort of current medical issues was poor, which was understandable given the patient's condition, lack of education. And his mother demonstrated adequate understanding because likely if he was kind of in and out of it, much of the transplant education had likely been provided to the mother. So she seemed to know. And we found that encouraging, that at least some member of the family is aware of what is being potentially discussed as an option for him. In terms of social support, the patient lives with his mother and brother. Parents are divorced. Mother appeared very supportive and was willing and able to be a caregiver post-transplant. And his two brothers were also very supportive. One lived in California. And I think he likely had said that he would come to help or be able to be available to him. So the psychiatric history, which was very important for us to be able to assess, there was a history of depression for this individual. He also, his mother mentioned to us that he had a history of anxiety and panic, which started at about age 15. He's hospitalized. He was hospitalized when he was 16 years old, and for psychiatric issues. And Lexapro, an outpatient follow-up with a psychiatrist, was recommended. He showed good response to that, and he discontinued when he was feeling better. The most recent concern was a suicidal gesture 1 year prior. He was hospitalized. Again, he was prescribed Lexapro and Seroquel, but did not fill for unknown reasons. Not sure if he couldn't afford or what happened. The patient also has a history of alcohol use. He was drinking until the current admission. He was drinking about 4 to 5 beers per night. And he was supposed to get substance abuse treatment. When he went for intake, they did not have a bed and he never followed up. So this is a very different situation from the previous. This is an individual that has pretty significant psychiatric issues. There's been this suicidal gesture, a hospitalization for psychiatric issues, active substance abuse. So these were the recommendations that we made. Time permitting, have the patient establish care with mental health services, that is psychiatry and psychology. Patient should also complete an alcohol rehab program and regular follow-up with AA post-rehab. And then he should also demonstrate compliance with all recommendations and follow-ups with the team. These are our recommendations, but of course, given the circumstances, because this person was in an acute liver injury, they may have, hospitalized him, monitored him, and seen if he improves. But if he continued to decline and needed transplant, this person would not be able to likely demonstrate compliance with any of these recommendations. So, that is similar to that question that was asked. Sometimes there's no time for some of this. And like I mentioned, 25 years old, that weighs heavy on this decision. And, I think there might be a lot of discussion for the pros and cons of transplanting someone like this, but I think in more likely than not, they would potentially move forward with listing and transplanting an individual like this. So I thought I'd just really quick. Do we have time? Okay.
Yes, we have time. And we can also go over a little bit if you have time.
Okay. So I thought I'd just include one or two slides from some of these talks that I've given on the ethics of making decisions, just because I think as young medical professionals, it's just important to sort of give some thought to, the roles that we play on teams. And I spoke a little bit about that. So, some of the reasons that this becomes an ethical decision is because we're rationing a scarce resource. And whenever we're doing something like that, that presents many ethical challenges. So there's this concept, the concept of distributive justice, how to fairly divide a scarce resource. Some of the things that we need to keep in mind when we are following this idea of distributive justice is, first of all, that there should be equal access to all. So whenever we make decisions about allocation of resources, that we're basing these decisions on objective factors aimed at limiting bias and unfair distribution. So the aim for organ distribution is to be free of medical or social worthiness bias. For example, poor lifestyle choices that cause illness. We know that a lot of times lifestyle choices about eating healthy, about, taking care of yourself really are dependent on socioeconomic status, where you live, access to healthcare, access to food. And so, that is an important consideration when we say how socially worthy is someone to receive an organ because they were not able to show compliance with follow-ups. Someone that has access to their own car has a very different ability to show up for medical appointments as compared with someone that has to get on 3 buses to come to a medical appointment. So I think that is something that we need to factor in when we're discussing these decisions about organ allocation. The second concept of distributive justice is with regard to maximum benefit, which is that the goal is to maximize the number of successful transplants. And for example, include medical need, that is sickest person first, the probable success of a transplant, who will likely live the longest. So for example, like I said, so this is the concept of maximum benefit, just to sort of elaborate, is what we might potentially use with that patient that we discussed, the 25-year-old in the ER. Okay. Psychosocial, so you can understand that with medical criteria, it's pretty black and white. A lot of times, a patient either qualifies or does not qualify for transplant. If the organ looks a certain way and the doctor is concerned this person is not going to do well on the table, it's a very black and white decision. Psychosocial criteria tend to present the most difficulty in terms of ethical dilemmas. Right? So my last example is patient C. This is a 22-year-old Caucasian female who presented at Loyola for consideration of heart retransplantation. This is a patient that I followed for a long time. She was diagnosed at age 12 with a congenital heart condition and transplanted at age 16. Her mom died from the same disease when the patient was age 7. So she's led a pretty hard life. She is extremely non-compliant. She was extremely non-compliant with immunosuppression, and that was suspected to be the reason for the organ rejection. And patient admitted to this at a later session. So here's this young girl. She's had this first transplant at age 12. It's not worked out because she was non-compliant with her immunosuppression. And typically, someone's non-compliant with immunosuppression, and that leads to organ failure. It's very hard to make a good case for them to be considered for retransplant. But this person was considered because of her young age, that concept of maximum benefit. Over the years, she also relapsed into marijuana use shortly after her first transplant and has repeatedly denied using marijuana despite positive drug screens. She has limited support. Her father is emotionally and physically abusive towards the patient. This was witnessed by us on several occasions when she came in. There was a lot. She would show up, and the whole clinic knew when she had shown up because there would be fights at the front desk with the father. The police had to be called. So this is a toxic, stressful environment for this young girl. Okay. There's no other identified caregiver. The recent incident with the police was when she called the police on her father because, he was, hurting her, hitting her. She has a long-standing history of poorly controlled depression, anxiety, little to no follow-up with mental health providers. Her follow-up psychotherapy sessions suggested manic, hypomanic symptoms. She's had one past suicide attempt in 2003, endorses passive suicidal ideation since then and currently. The one thing that she had going, she said she expressed strong desire to pursue transplant and willingness to improve compliance. She admitted she did not fully understand her illness because she was in denial when she was diagnosed at such a young age. Consequently, she reported that she tried to push it away. However, she reported that she has since recognized that her behaviors can contribute to her health and longevity and understands that if she does not adhere to medical recommendations, she won't live very long. Okay, so this is a difference. At 12, a lot of people make many silly decisions about the health issues. Don't take it seriously. She's 22 now. So on the SIPAT, this patient was a high-risk candidate. We would have, based on the SIPAT, recommended deferral while identified risk factors are satisfactorily addressed. Okay. What are the ethical considerations? Age, social worthiness, that she contributed to failure of her first transplant. Okay. Should a patient be considered for a second transplant if they have already received one? To play devil's advocate, no fault of the patient that she has limited social support. So while she desires to improve compliance, no actual behavior changes have actually occurred in the right direction. So even though she says that she wants to do better, she's not demonstrating that she's doing better. So unfortunately, the idea with something like this is just when we lay out, it gives us good pause to sort of think about an individual's candidacy and worthiness. With this patient, a decision was made to deny retransplantation. And a lot of the reasons that were listed was this ongoing non-compliance with medication, active use of marijuana and alcohol with limited insight and motivation to remain abstinent, bipolar disorder, which the patient really was not sort of cognizant of and had any desire to want to sort of be consistent with follow-up about. No functional support system. Her father was a terrible support and she had no one else. And she's medically higher risk than first transplant. So we know that the second transplant is already that much more difficult and has many more medical complications, and she probably needs even more trips to the hospital. And here she hasn't been able to manage the first one. So, the decision was made that this, as much as, it was very difficult to make a decision about denying transplant, we believe that it was in her best interest that she would not be able to support another organ and that it would lead to significant decline over the next couple of a year or two after transplant. So what questions can I answer for you? I hope that this has been able to give you a good review of what my work does with organ transplant, the role that I play on the team, and also an ethical consideration of some of these very difficult decisions that we have to make based on psychosocial criteria. Okay? Have there been any other questions?
Not that I've seen. Oh, here's another one. Mm-hmm. How have candidacy criteria changed now, given that medical marijuana now exists?
Yeah, they haven't changed yet. So there are no candidacy requirements for marijuana. Different programs have their own criteria about what risk they potentially want to absorb. So, this 6-month policy is a Loyola policy. There are many transplant centers that don't have a 6-month policy. It is really about the risk for, substance use that different centers want to take on and absorb. Different programs within the institution too may have very different criteria. I think we do have these conversations that have come up. Some of the cardiologists have been concerned that, with patients using more medical marijuana for management of pain, do we need to update some of our criteria? It's an ongoing discussion. There's no consensus about it at this point.
On average, how often do you do emergency evals like the one you mentioned in the ER? And more generally, how many evals do you do weekly or monthly?
The emergency evals in the ER are really are very rare, and they happen mostly on the liver transplant service that one of my colleagues covers. I don't do any. In an emergency, we may do an emergency eval on an individual that maybe, has suddenly developed some cardiac complications and needs to be on, life support or something like that. We may do, say 2 or 3 a month at the most, and even not even that many. I would say 0 to 3 a month. On average, I might do about 6 to 8 evaluations across heart and lung transplant in any given week. And that would be on the inpatient and outpatient services. So they're busy services. We work up a lot more patients than get listed.
Well, thank you so much for all of the information and also highlighting just how weighty the considerations are in deciding somebody's transplant candidacy.
Yes.
I'm just wondering, based on just how heart-wrenching the last case example is there any opportunity for, any psychological intervention or any help with medical compliance that would have helped her outcomes with her current heart transplant?
Sure. I think that, there was a lot. We've intervened. So this individual received heart transplant at another institution and then transferred care over to us. So a lot of years were lost in that transition. But as soon as she became sort of aware on our end, we tried to schedule follow-ups with psychology, follow-ups with psychiatry. There was a lot of inconsistency with her follow-up. Sometimes she would show up, sometimes she would not. And we know that the lack of consistency just doesn't allow us to be very effective with trying to implement change behavior. So it was difficult in that way. When this individual was declined for transplant at Loyola, we still offered her, ongoing follow-up in the cardiac clinic, and in addition to follow-up with psychology. We also referred her to other centers. So just because one center turns you down doesn't mean that you can't potentially pursue listing at other centers that might have very different criteria. And ability, they may do more transplants in the year, they may absorb risk differently. So we always, give them names for centers that they could potentially go to and pursue transplants.
Thank you. So it sounds like there are options and there's opportunities that you provide. It's just a matter of follow through.
Yes. There's another individual that for medical reasons had to be declined for transplant. It's been 2 years out and I'm still seeing her for ongoing psychotherapy. So I don't think the individual just sort of is lost at that point. There is still some desire to continue to offer whatever medical interventions or psychiatric interventions we can. Thank you.
Well, thank you so much. If you don't mind, would you give me permission to provide your email address and potentially your slides if people ask, in the next couple days?
Oh, yes, absolutely. Please. And if anyone has any additional questions or follow-up comments, please email me. I'm happy to be available to discuss anything.
Thank you so much, Dr. Merchant.
Thank you. Thank you for this opportunity.
Yeah.
And it's nice to be able to speak with all of you.
Thank you.
All right. Bye.
Bye.